Hello guys, welcome to my YouTube channel, Tutor Med, where everything medicine is simplified. I am Dr. Kofi, a medical practitioner with the passion of teaching everything medicine. And so in our last video, we had a tutorial in internal medicine where we discussed a clinical case of chronic kidney disease from a possible diabetic nephropathy. In today's video, we will have a tutorial in surgery. And as usual, if you are new here, you want to consider subscribing and hitting the notification bell, because I guarantee this is what you just need if you are preparing for any licensure exam. Alright guys, let's get started. And so for today's clinical case, we have a young man who was involved in an RTA, which stands for a road traffic accident, and he sustained a fracture of the femur. There was no break in the skin, and he was brought to your health facility. Question 1 says, mention 2 things you will elicit to tell that the part of the limb below the fracture is viable. Now let's spend some 20 seconds to think through the question. Great. And so as established earlier on, one of the things to do initially is to fish out the relevant information in the clinical stem. And so for the relevant information here, they include the fact that he's a young man and the fact that the mechanism of injury to the femur was a road traffic accident. And the part of the body involved is the thigh, and he had a femoral fracture. And the fact that there was no break in the skin. This is very important. This last information is very important because it tells us the type of fracture the patient has. And it's a closed fracture. Now, if there were a breach in the skin such that the external environment communicates with the broken bone or the fracture hematoma, then it will be an open fracture and the management will be different. Now, back to the question. It is asking us the things we will do to prove the leg is still viable. In other words, how we will tell that the leg is still alive, the part of the leg below the fracture. And so, what you will do is to check the blood and nerve supply to the limb. And if they are intact, then most likely the limb is viable. But please note that for the answer, you won't write intact blood and nerve supply as I have indicated. You will write what you will do to prove that there is intact blood and nerve supply. And so what will you do to prove that the limb is viable? You can palpate the popliteal or the posterior tibial or the dorsalis pedis arterial pulse. Once you feel the pulse and it has good or adequate volume, then most likely the limb is viable. That is a test of the blood supply. Then for the nerve supply, you can test for light touch sensation or 2-point discrimination. Once they are there, then most likely the leg is viable. So they asked for 2, and so we limit ourselves to 2. But other things we can do are to check for capillary refill time on the toenails, and it should be less than 3 seconds, indicating adequate perfusion. It means that the arterial blood supply is still intact. Or we can test for motor function, which is a test of the nerve supply. And so these are the answers to the first question. What will you do, or what will you elicit to tell that the part of the limb below the fracture is viable? Now on this slide, let's show the bone which has been fractured in this patient. Now this is the thigh bone, medically called or anatomically called the femur. It is the strongest long bone in the body. The fractures of the femur can occur in the neck of the femur, the shaft of the femur, and then above the condyles of the femur. It means you can have a femoral neck fracture, you can have a shaft fracture or a femoral shaft fracture, and then you can have a supracondylar fracture of the femur. Now, considering the mechanism of action in this patient, the mechanism of injury, I should have said, in this patient, most likely the shaft is involved, but it can occur anywhere, including the neck and then the supracondylar region. Good. And so please do not forget to like and share this video and subscribe to the channel if you have not done that yet. Now, the second question says, mention 4 investigations you will carry out in this patient. And here, obviously, one of the first investigations the patient needs is a plain bone radiograph or an X-ray of the affected femur, showing the joint above, which is the hip joint, and then the joint below, which is the knee joint. And the X-rays should be taken in 2 views: the anterior-posterior view or the AP view and the lateral view. Then another important investigation is blood grouping and cross-matching against at least 2 units of blood. The reason is that femoral fractures can cause about 1 to 3 liters of blood loss and may result in hemorrhagic shock. And this may occur when the fracture injures the femoral artery, and so there is a need to secure blood because these type of fractures may be associated with significant blood loss. We need to know the patient's blood group so that we can cross-match and then secure blood for him in the event that he has really injured his femoral artery. Then again, an abdominal scan should be requested because he may have sustained an abdominal injury. He had an RTE. The RTE might not have affected only his leg. It may have caused some organ damage in the abdomen, so we need to scan his abdomen. And then we can also do a full blood count to look for the anemia. If he's truly losing blood and then the blood loss has occurred over a significant period of time. But realize that acute blood loss might not change the HB that much. But if it has occurred over some period of time, it may cause anemia in the FBC picture. Then other investigations that can be done include X-rays of wherever he complains of pain. And so if he complains of pain in the arm, we need to X-ray the arm. He may have had a fracture in the arm. And then if there is a history of loss of memory or a transient loss of consciousness or a reduced GCS, or he had a history of bleeding from the nose, bleeding from the ears, there may be a sort of head injury, and so he may need a head CT scan, a plain head CT scan. And so the third question, question C, says, what will be your initial management for this patient? Now, all trauma cases, especially those resulting from RTAs, are emergency cases, and we need to manage them using the emergency protocol, A, B, C, D, and E. And so quickly we do a primary survey. And for the primary survey, A stands for airway and then C spine stabilization. And so we ensure that the airway is patent and the cervical spine is clear of injury. And if there is any suspected cervical spine injury, we need to stabilize the C spine. And then B for breathing. We need to ensure that the breathing is normal and it occurs spontaneously, that the patient does not need any ventilatory support. Then C for circulation. We need to ensure that the circulation is good, evidenced by a good pulse and then a normal blood pressure, especially for this patient who has had a femoral fracture. Remember, we said it can cause significant hemorrhage, which can cause hemorrhagic shock. So we need to check the circulation very well to make sure that the pulse is not weak and thready and then the blood pressure is not going down. And then we want to make sure that there are no catastrophic bleeding sites. I meant to say catastrophic. Then D stands for disability and then neurological status. So the neurological status, you want to check his GCS. You want to make sure that his pupils are reactive to light. The location should be central. And then he has a normal RBS. E for environment and exposure, but we won't go through that. And then after the quick primary survey, which identifies immediate life-threatening conditions, we do a quick secondary survey by taking ample history. The ample here is an acronym for something. And then we do a brief head-to-toe examination to find other injury sites. Then after we are clear that the patient is stable, then we reduce the fracture, the femoral fracture, if it is displaced, but ensure that the blood and nerve supply are intact after reducing the fracture. So you ensure neurovascular integrity after reduction of the fracture, and then immobilize the fracture with a splint. Then after that, we ensure adequate pain management. Now, immobilizing the fracture is a form of reducing the pain. Then after the fracture has been splinted, we can elevate the affected limb. It also controls the pain. Then there is application of ice. All these are measures to ensure adequate pain management. And then we can give some pain medications like some NSAIDs and then some low-dose opioids if indicated. And so the principles are a quick primary survey, a quick secondary survey, and then you immobilize. First, if the fracture is displaced, reduce it, but make sure that after reducing it, the person's blood and nerve supply to the limb is still intact. Then you splint the reduced fracture, and then you ensure adequate pain management, initial management. Now the fourth question says, list 4 complications of the patient's condition. Now acutely, one of the complications that can occur is acute compartment syndrome. Now this complication occurs when there is pressure buildup in the various compartments of the thigh, resulting in compression of the blood vessels that run through them. And so these compartments are formed by rigid structures like the bone and then the fascia. After the fracture, inflammation follows, and then the edema within the compartment from the inflammation expands. But because of the rigid boundaries of the compartment, the structures within the compartment, which are flexible, suffer the pressure of the edema, and so they include the blood vessels. So that is called compartment syndrome. Then another complication that can occur is vascular injury, which can cause shock. Like we explained, the fracture itself can injure any major blood vessel that is running through that place. Then one of the late complications include delayed union. That is, it is time for the fracture fragments to unite, but for some reason, because of an infection or something, they are not uniting. So that is delayed union. Then we have malunion. So this time they have united, but the alignment between the 2 fragments is not perfect. So that is malunion. So the question says 4, and so we stick to 4 answers. And so there are more complications of fractures, and this picture I got online will help illustrate them. And so kindly look through them to learn more about the complications of fracture. But because you are sticking to answering the question, I won't go through all these, but in your free time, you can go through these complications. And so thank you for watching this episode of Exam Prep Tutorials, and please do not forget to like and share our videos, and then subscribe to our channel. Thank you once again. Bye.
Thank you.